speakers. So now we are moving to the last session of the day. That is open house session, anything and everything about GBC. And to deliver this open house session, to conduct this open house session, I would like to call upon the dais, our moderator, Dr. Anu Behari ma'am. Dr. Anu Behari ma'am is a senior professor in the Department of Surgical Gastroenterology at SGPGI Lucknow. And we have a panelist for the session, Dr. Ankur Punia. Dr. Ankur Punia is Associate Professor in the Department of Medical Oncology at Mahatma Gandhi Medical College. Dr. J. Mehta sir. Dr. J. Mehta sir is a Senior Consultant and Head of the Department of the General and Minimal Invasive Surgery at Narayana Hospital, Jaipur. Dr. Sanjay Sharma sir. Sanjay Sharma sir is the Professor in the Department of Surgical Oncology at Mahatma Gandhi Medical College, Jaipur. Dr. Nijhawan sir, we don't have another panelist.
5 minutes early, so he may be on the way.
Okay. Yeah. So might be Dr. Nijhawan will join the meeting because we are 5 minutes early. So, all of you are supposed to sit this way. Ma'am will moderate the session. Yeah.
We are 5 minutes early, so it's okay, you start.
So Dr. Kapoor said this is an open house, like anything and everything about GBC. And when I asked him about the format, he said, no, truly open house. So, so the panel, so we have the good luck of having a surgeon, medical oncologist, surgical oncologist. So any question from anyone in the audience on any aspect of gallbladder cancer. And if today we have been discussing incidental gallbladder cancer, so if any questions have remained unanswered, or we want to reiterate, or we want to confirm. So, or maybe I can start the ball rolling with a few questions. We, like in the last presentation, we said we want to know a lot of things about the index cholecystectomy, bile spill, there is higher risk of peritoneal contamination. So, yes, we have this information. So how does this change your management in day-to-day in terms of how you stage this patient, how you approach this patient for management?
We have already discussed in our lectures that basically we should have information of T level, that what is the T1, T2 or T3 or T4 level. Then lymph node involvement. The lymph node involvement, especially whether it is hepatoduodenal ligament is involved or it is beyond that. Some people are, especially Japanese, are taking out the celiac and aortic lymph nodes. But most of the studies, they take as a metastatic disease. So the information must be there. The third thing is liver involvement. How much is the liver involvement? Whether it is a micrometastasis or whether it is a beyond needs hepatic resection. So all these information is needed for extended cholecystectomy, and where the surgery is our first choice, we need these information. Other information which we have already talked about, that if there is any spillage of, we have talked that spillage is there, perforation is there, or bile, cystic duct involvement is there. So all these information will change our treatment, or if there is a distant metastasis, which is bilateral involvement of the liver, diaphragm or lungs. So in that case, it will change. So all these index, what you have already discussed, it will immensely change our treatment, line of treatment in these cases.
So, my point specifically in the context of IGBC was that if there has been a tumor breach, if there has been bile spill, the procedure was done laparoscopically. Does your management in terms of staging or management differ, and in what way? Like
yes, ma'am, that is very important to know that how the previous surgeon has performed the surgery. We need to, if possible, we need to talk to him, and as the previously discussed, we need to review the slides and we need to see the operative procedures. because it is completely going to change the management. Suppose there is some bile spillage is there. So bile spillage means it's almost peritoneal carcinomatosis has occurred. So it will be staged in a different way and treated in a different way. If previous surgeon has extracted the gallbladder without the gallbladder bag through the port, so again, though some surgeons say that port site excision is better, but studies have suggested that port site excision does not improve the survival. So overall these things change the stage, how the previous surgeon has.
I agree totally. So my point was that does the sequence change? Say for example, there is a patient without bile spill, there is a patient with spill, patient in whom the gallbladder was extracted without any bag, we know that for sure. So when we are looking at this patient in like staging and further management, like will some say the sequence of investigation be different? Say for example, would we do PET scans more often in these patients? Would we do a staging laparoscopy, re-staging laparoscopy in these patients more often?
See,
Compared to another person who has not had these, and it's the same stage, same T stage.
so in same T stage, whether peritoneal metastasis has occurred or at immediate PET scan won't be able to give much of the information at the same T stage. But still, we will I don't think so there will be any difference in the investigation or our treatment point of view will be different. But in making up the staging purpose, I think whole things has to be done.
Okay.
Right.
Non-perforated, no spill versus perforation and spill. How would you change the treatment for us?
So in PT1A, we need not to do much of the things. If there is no spillage and the extraction has been done fine, there is nothing like that. Similarly, in PT1B also, PET scan with spill is the stage will change.
Management will change.
The management, it will be treated as a upstage disease, so it is not possible to go for R0 resection in that stage.
Now, I think what the point that Dr. Sikoi is trying to make is that normally for T1A, nothing else is required. This is intact gallbladder extracted very well. Vis-a-vis T1A, so from the T stage it doesn't require anything else, but now bile has spilled, which we take as a very important prognosticator of peritoneal dissemination. What do we do different in this patient?
Specifically, would you give
Adjuvant.
or you would observe this patient?
Bile spillage, as already discussed, is a high risk factor because as such for T1A, we won't give any adjuvant treatment, just surgeries. Yes, sir. So if it's a bile spillage and T1A, then we might consider for a adjuvant treatment. We don't know whether it might benefit the patient, but still it's a high, because it's considered they have a higher chance of a recurrence. Adjuvant chemotherapy can be considered, but not proven per se in this particular subgroup.
Dr. J, you were trying to make some point.
There has been a lot of questions about lap versus open. Now suppose I say that there is a patient, say one patient who has undergone a laparoscopic cholecystectomy, having a T1B disease, another patient having a open cholecystectomy underwent a T1B disease. Will your management change in either of the two? We have been having this point since morning, whether it is lap or whether it is open.
Well,
So just for that sake.
the various studies have shown that long-term results and clearance of extended cholecystectomy are not different whether you are doing a open or a laparoscopic cholecystectomy, right? But there are some controversy in some literature that open cholecystectomy, but it depends on the experience of a surgeon. Now, second thing, if it has been done a open cholecystectomy for first surgery for cholecystectomy, then it is better to do a open cholecystectomy for extended cholecystectomy. But if it has been done a radical laparoscopic cholecystectomy, then you can go better with a laparoscopic extended cholecystectomy.
I think if the gallbladder is not perforated, if the gallbladder has been handled well, if it has been extracted in a bag, I don't think it will make a difference whether it is laparoscopic or open.
So primarily, if every care is there, laparoscopic or open does not make any difference.
Yeah, but because we have
Until
taken laparoscopic this thing as a surrogate marker of
primary
higher, that way, also and a higher risk of gallbladder perforation,
now-
but the fundamental thing is not the same.
If that is the primary discussion, actually there were a long sequence of questions. I wanted to just end with one. But now the second one comes is, if you have done a lab coli, patient is having a tumor, now we are extracting without a bag or with a bag, but then will the other ports also have a significance? Will you like to remove the other ports also? Third thing, since there is already a gas which is in the abdomen, will it lead to more of peritoneal dissemination? If there is a bile spill, it will lead to a peritoneal dissemination at the local site, or you will consider it to be a disseminated disease elsewhere also. Will it get more benefit for adjuvant therapy, which he has already addressed? And now, with the bile spill, what is the best investigation that you can do to assess whether there is a local recurrence? Because subsequently, we will go for extended coli in this group of patients if he comes referred to you. So these are, there have been a lot of thought-boggling things which has been going on. So maybe you can answer one by one.
So regarding you are particularly asking for T1A lesion only, no? T1B. T1B lesions, even the PET scan has got in study from Tata that has got 100% negative predictive value. If it does not show any uptake, we can, though lymph node removal has to be done, so liver dissection can be avoided in those cases with a negative PET scan. And regarding the port site excision, the study from MSKCC single study maker has said that there on the patients in which port excision was done, there was no difference in overall survival at this compared to the same T stage. Rather, they were having more chances of 15% more chances of incisional hernia on that.
My question arises from the previous discussion that T1, obviously incidental GBC deals with T1 stage mainly, A or B. So if T1, preferably we should take, because we should be very clear in this session that preferably we should take by laparoscopy, preferably by open. Like that message should go that whether if we are taking it by lap, what are the rules to be followed which are nearly outlined in the past, like the gallbladder should not be ruptured, should be handled delicately, should be removed in endobag. Suppose if bile spills, then what measures intra-op we can take to reduce the spread of that bile? And I am not sure what literature says about the bile cytology in such cases, whether it's positive or not. So these are the points to ponder in T1 stage with laparoscopic cholecystectomy.
Sorry, before the panel takes this question about this, that most incidental gallbladder cancers are T1A or B. If you see the large series, T2 is
maybe,
actually
yeah,
the
yeah.
most common, and a lot of T3s also actually.
That's fine,
So
that's
it's
fine.
not that all of them are T1A,
Most.
please.
So in patients with T1 lesions with bile spillage, what the thing is to be done? Nothing. We have to wait for the things and.
I'm asking about intra-op also.
But I think because we are talking of incidental gallbladder cancer, the surgeon doesn't know that, he or she is dealing with
Okay.
gallbladder cancer. So it would be bile spill, they would do suction, they would irrigate, they would do the
routine
usual
cleaning
things
and
for,
that thing is that,
I mean, what they
Right,
usually do.
Right. But when we operate on polyps and all, we need to be careful actually about
need
this.
to be
Yeah, the
careful.
need to be careful is definitely.
Yes, and we need to do as routinely go for wash, and if histology comes out to be positive, then nothing more. And we have to treat whether to go for adjuvant treatment or not. We will.
I mean, at least I think about the PET scan, as you have mentioned, but not all groups do routine staging laparoscopy for re-resection for IGBC. It's not a routine. But I think if bile spill is there, even if PET scan is not picking up the peritoneal metastasis, and especially if some significant time has elapsed, I would definitely do a staging lab, even during the re-resection, to pick up the peritoneal metastasis.
So I feel that bile spill should not change the plan of management. If it is T1B or beyond, even if there was bile spill, unless any of the investigations show distant disease, re-operation should be done, but the patient has to be told that the prognosis will not be as good as it is in a patient who did not have a bile spill during the index cholecystectomy.
And maybe the threshold for adjuvant therapy
Yes.
would be lower. I mean,
both for investigation and adjuvant therapy. And second, the question which Dr. Sikora asked, if it is T1A, bile spill, the only difference would be what Ankur said. In fact, I would say it more strongly, that I would probably advise this patient to have adjuvant chemotherapy for whatever it is worth. Because we know that the disease cells have spilled in the peritoneal cavity, for which surgery is not the answer. So the only answer is adjuvant chemotherapy. But for T1B and beyond disease, and this is a question which many students are not sure what to say, or many surgeons are not too sure what to advise to the patient, we must come out with clearly that bile spill alone should not contraindicate re-resection if there is no other contraindication.
Yes, that's right what sir is saying, that because it is difficult to within 4 or to 8 weeks to see any peritoneal deposits that can be picked up by any PET scan or diagnostic laparoscopy after bile spillage. So it may, in a later course of time, it may develop. Yes, sir.
Can I do a question? Can I do a question?
I'm sorry.
Can
Yes,
I do a
please.
question?
Yeah, please.
Sorry. First of all, I would like to congratulate, because you see, you analyze all the aspects. This is fantastic. Congratulations. Simple question. If you have a bile spillage, you can use hyperthermic chemotherapy, like a Schucker-Becker procedure.
See, intraperitoneal chemotherapy. There has not been any evidence of having an intraperitoneal peritoneal chemotherapy at present. You are talking of the HIPEC. So it has not been any evidence what can be done on a trial basis if bile spillage is been done.
So actually, we have done a study in AIMS for HIPEC, not exactly in incidental CAGB,
Right.
but in GBC. But unfortunately, the results are that, as we always say, that GBC is more of a systemic disease. We haven't seen any change in the appearance of distant metastasis as far as HIPEC is concerned. So HIPEC hasn't really replicated the same that it usually does in other malignancies. Per se, HIPEC is not a very good modality. Even if there is a bile spill, then all the more the tumor cells have already spilled into the peritoneal cavity. So further poorer results must be there.
I don't think there are studies for like prophylactic kind of HIPEC, that if spill has happened, and I'm not aware.
We have done a study with one of our residents.
For incidental?
For GBC.
For
So when we were
GBC.
doing extended cholecystectomies, we were giving HIPEC. There were no distant metastases, did not have any peritoneal metastasis. But unfortunately, when we compared both the groups, there was no significant difference as far as the peritoneal metastasis coming or disease recurrence, systemic disease recurrence was there.
It's probably a representation of surgeons still trying to do local things for something which is
that
systemic.
kings and queens and prince and princesses time.
Still it's
So, I mean, what I feel on this is, I agree that when there is bile spill, the risk is high, this is the opportunity to treat, we should do adjuvant therapy. But I don't agree with what Dr. Kapoor said, that even if there is a spill, you should go in and operate. I think that patient should get neoadjuvant therapy. That patient should get a time between the re-exploration to see how it manifests, whether it manifests with peritoneal disease or no. And if you give neoadjuvant therapy, adequate time, and if there is no local disease, then one can consider if you still feel that re-resection is an option in that. So, in one stage, if you want to do adjuvant, why not a neoadjuvant with bile
Yeah.
spill?
In fact, sir, I personally also feel that for all these markers of high likelihood of residual disease, we should be doing at least some trial. In one arm we have upfront surgery, in other we have neoadjuvant chemo or chemo-RT, and then surgery. I think from Tata Memorial, they have recently in 2023, like where they have lessons learned. There's this thing where it's their overall experience, but in between they have talked about IGBC and the locally advanced, where they give 3 cycles, chemotherapy, then do surgery, and then again give chemotherapy. So I think we can extrapolate to the IGBC.
No, actually, we haven't published our own data, but when I left, Dr. Jitendra had already done a study where actually more than 200 patients were there of IGBC. And the only results that were there was adjuvant does help, re-resection does help, only in few stages, especially T1B, T2, because the Omega study, somebody quoted an Omega study. Unfortunately, Omega study is saying that even T2 does not require re-resection.
See, the thing is, T2 is not T2 is a spectrum.
Yeah.
You can have T2N0, you can have T2N plus, and you can have T2 minus the pathological factors, you can have T2 with those pathological factors, and several other unknown biological factors. So T2 is not one thing. So that is why that probably reflects in a very variable, even within the T stage.
But
and
I
lymph node
guess,
involvement.
Why we shouldn't be quoting Omega studies, because that is more of surgeon preferences rather than objective data. If you go, I myself actually I'm part of Omega collaborator, but still I personally feel that T1B and above do require resection.
If not for anything, but for adequate staging.
Yeah. The staging part, sir, I would still feel that it will not be staged properly because if there was a tumor in the resection bed which was not picked up by PET scan and was then picked up in the histopathology, probably the stage is slightly different than when there was no tumor in the whatever resection we did, 2 centimeter or 4B5, whatever is the patient surgeon preference. So both ways the stage differs, and lymphadenectomy is actually more important than the liver part. The Koreans, I spent some time in Korea with the Dr. Han's group, probably tomorrow sir will be there. So there they are going to publish a data about T1B, whether they don't do the wedge part but do the lymphadenectomy for them. Similarly for T2 also they are comparing between doing the liver section and lymphadenectomy versus only lymphadenectomy, and they have data they might publish in the near future. So there are differences, and as you said, probably we also need to study more on what exactly is to be done in these kind of issues.
I think there is some data from Tata also. Means having T1B PET negative patients, only lymphadenectomy.
Only lymphadenectomy.
No liver.
They are also starting to.
No liver resection.
The same discussion is there. They are discussing among themselves.
No
this
liver
only,
resection needed.
whether the liver resection actually required, and if required, in what patients actually liver resection should be done. So subset is there where actually you will require liver resection, but you have to carefully select these patients. That is.
Dr. Nisar.
Ma'am, as part of this staging protocol for incidental gallbladder cancer, contrast enhanced CT scan forms the standard protocol for evaluating incidental gallbladder cancer. When should we add contrast enhanced MRI to the workup?
Yeah, you mean MRCP or MRI? Both.
MRI.
So MRI, they say that if there is a metastatic, if there is a metastasis, to detect the metastasis, if there is a doubt on CT scan or the things are not clear, then we can go for MRI. Then they are more contributive to each other. So basically, they do better for the metastasis.
On contrast enhanced CT scan, if we already have a suspicion of, or if we have any lesion suggestive of metastasis, we can simply go forward with the FNA and confirm or refute it. Then is there any additional role of contrast enhanced MRI?
See, the biliary duct involvements and all, they are better seen on MRI, but contrast enhanced CT scan is, phase CT scan is much better than.
Because early in the presentation, I don't remember that gentleman's name, he was insisting that he would prefer contrast enhanced MRI as compared to the CT scan.
But if CT scan has shown metastasis,
no, otherwise also they were insisting that no, CMRI should be preferred as compared to the CCT. Yes.
Just just wanted to know, is there any role of intraperitoneal wash and cytology during second surgery in a patient who had bile spill? So we can,
Sorry, intraperitoneal
like in
wash.
ovary we do it.
Well,
So,
intraperitoneal wash, it is then, it will add to the diagnosis, but it is not 100% foolproof that you will detect the smaller metastasis. So it can, with laparoscopy, if you put some saline and do the, cytology of that fluid, that will help in the micrometastasis.
and my question to medical oncologist also, if it is positive, suppose in second surgery I have done intraperitoneal wash and it's positive, should we proceed for the resection, RZ resection, or should we stop and give the neoadjuvant or adjuvant, whatever you call?
If peritoneal cytology comes positive, then it's basically peritoneal disease.
Yes.
The patient becomes palliative irrespective what kind of resection we do. I don't think there is a benefit of going for surgery in such cases.
So ideally it should be added in a part as a part of our procedure in second surgery? Question to the house.
So, see, though the peritoneal washing has not been, there is no more data on that, but still that can be there if previously bile spillage has been done.
Yeah,
it is
that's what-
difficult
then
to
that's
pick up
needed.
so early the malignant cells at this stage, because that is done at an interval of 4 weeks or within 8 weeks only.
So we are doing second surgery at the interval of 4 to
4
8 weeks only.
right, right.
So that's why I'm asking.
So if it is positive, surely we need to.
So I think it should be included in as a part of this thing, second surgery, that you should always do peritoneal wash and check for the cytology. That's
But I
what
think
just,
we'll probably have to do a prospective study to see the exact sensitivity and specificity to be able to say that.
Ma'am, if there is a bile spill during the index cholecystectomy, so is there any role of normal saline or distilled water if we wash the peritoneal cavity, it will reduce the risk of peritoneal carcinomatosis or not?
So there has no been data because it is previously it is an incidental. We don't know whether there is and bile spillage occur. Peritoneal washing, whether it reduces or not reduces, there has been no much of the data, and there has been we can do that. That is different thing. At present, there is no data on that. Routinely, we are doing that. Huh?
You are doing routinely? Yeah, at the time of resurgery?
No, no.
For CAGB?
Normal gallbladder, ma'am?
Oh, or giving a wash, yeah. Yeah, that.
No, actually, I want to know, I am read from somewhere like distilled water is much better than normal saline. So what your comment, like, is it true or like still in?
I don't find which goes routinely. I've seen only the use of normal saline during surgeries. Use of distilled water, I don't see if any.
Yeah, sir, I think Kapoor sir will.
Yeah, actually I used to do it not in cholecystectomy, but if you are dealing with a malignant disease and there is spill, then rather than washing it with saline, because saline is only mechanical washing, whereas distilled water will cause autolysis of whatever cells are there because of water getting into the cells. So that was the hypothesis. You can use either distilled water or hypertonic saline. Distilled water is easily available in the theatre because there are so many ampoules of distilled water lying there.
So I think so we should also be noting down points for future trials or studies that arise from these discussions, because we really don't have exact answers. We really don't, especially from our area.
Another pointer regarding the bile spill, one thing which should be mentioned at least in the OT notes, or which we should say that it should be done, is whether the spill is controlled versus an uncontrolled spill. There was a group which actually looked at this, and they showed that in uncontrolled spill, the distant metastases were significantly more compared to a controlled spill. Controlled spill, I'm saying in cases where you either open the cystic duct to do a IOC, or you intentionally decompress the gallbladder when you're not able to hold the gallbladder. Just a pointer.
Yes, there are many studies that bile spillage during doing cholangiogram has got less chances of recurrences than gross bile stillage.
Yeah, no, just making a point that it
So
should
it's
be noted down in the OT note, or at least it should come in our consensus that it should be noted down. Thank you.
Sometimes in cases of difficult lap coli, when we find it difficult to grab the gallbladder, it's a usual technique to put in an aspiration needle and aspirate. Suppose that patient turns out to have malignancy in histopathology, so should that be done, or?
So
That is exactly the point that I was making, that there was a study which looked at this, whether this intentional decompression leads to an increased incidence of metastatic disease, and they found out in there, I think the numbers were lesser, but less obviously, but they did find that when it was an unintentional, uncontrolled spill, then the incidence of metastatic disease was more compared to intentional decompression.
So
Dr. Ajay, you said there were more questions to come.
You are asking whether to hold the gallbladder and go for decomp. In incidental gallbladder GBC, we are doing surgery as per a normal benign disease. So I think if we find some sonographic finding or we suspect, then only, otherwise we should not, we can routinely, for a benign disease, we can go for it in a controlled fashion. Yes, yes, it's a tense.
Okay, first one, circumferential thick wall gallbladder. You want to do a anticipatory extended cholecystectomy, meaning to say you want to remove the wedge of the liver. What is the size of the wedge that you want to remove? 1 centimeter, 2 centimeter, 3 centimeter. I think Dr. Anu has a publication, so maybe you can directly.
No, today I am asking the
Dr. Anu's answer I
questions.
know, so I want somebody else to answer that.
We need the answer of someone who was not in favor of
Okay,
this.
I think, sir,
Sir,
I
if
think
you start
can
with-
comment on that, because that is important.
In fact, there is a counter question from me. In extended coli, how do we know 2 centimeter? Why not 3? Why not 1? Why not 0.5? Why is it 2? So I think it's very arbitrary. There is only one publication from Japan where they did multiple serial sections of the liver, and they showed that micrometastases are usually confined to 2 centimeter. That also I dispute. What is the anatomical basis that micrometastases have to be confined to a certain distance? If the tumor has gone into the bloodstream, it would go anywhere. So my point is, initially when we described AEC, we said 2 centimeter because the standard for EC also was 2 centimeter. But my question is that even 2 centimeter is not sacrosanct. Even 1 centimeter may be good enough. In fact, there is a very recent publication where they have shown that a smaller wedge gives rise to less morbidity. So that is why I am going to say that AEC, if you are doing in a low suspicion case, you take maybe even 5 millimeter wedge of the liver. Idea is to stay clear of the tumor if the tumor is there in the GB wall. That is the basis of AEC. So I think I am going to redefine the definition of AEC from 2 centimeter wedge to a small wedge. We may or may not say how many millimeters.
So maybe this is this thing for another study where we look at all our extended cholecystectomy specimens and the liver wedge and see in how many did we find the micrometastasis and up to what distance. Like
more the
Wedge is not to take care of the micrometastasis. In gallbladder cancer, if you are saying there is a discrete metastasis, whether it is micro or macro, it is a metastasis.
Yeah.
Wedge is to keep the margin clear, to have an R0 resection margin. That, whether it is like 1 millimeter as in colorectal metastasis, or whether it is 5 millimeter or it is 1 centimeter, nobody knows.
No, so I'm just from the study that you were quoting that the 2 centimeter came from this thing that usually it is not beyond.
No, I'm not sure whether it came from that or whether it said that 2 centimeter is good, because you read the German cancer registry data on incidental gallbladder cancer, they say if it is T2, they recommend a 3 centimeter wedge.
Sir, if we do the AEC and if you remove the 5 mm only wedge and it comes positive, then again we have to 2 centimeter liver wedge or just lymph node resection?
That is what I am saying. For a standard EC also, why 2 centimeter? Why not 5 millimeter? Who says? Margin has come positive, yes. Margin positive, but that is why selection of cases for AEC has to be good. AEC would be done when you have a suspicion preoperatively. So that means you must have done a CT or an MRI. That should show whether there is liver infiltration or not. If there is liver infiltration, treat it as like gallbladder cancer, do a standard EC, whether you believe in 2 centimeter, 3 centimeter, 4B and 5, whatever your policy. AEC would be done when the suspicion is low, when there is no liver infiltration. So if you take 5 millimeter wedge, why should it be positive?
I would extend that term. I think I want to tell sir earlier also, our intention is only to go beyond the cystic plate. Intention is not to go into the liver. We are not going in the liver if we have high suspicion. We're just removing the cystic plate en masse with gallbladder so that we don't breach that area which is just adjoining to it, because there is no serous over there. Now next thing is, suppose you have a gallbladder mass and you think you want to give him new adjoint. So which is a better investigation, FNAC or a biopsy?
Biopsy.
Preoperative.
We have a Dr. FNAC or biopsy?
No, but for preoperatively, you have a GB mass.
Yeah.
You are asking for a true cut biopsy?
I'm asking, you have to give a new adjuvant, so what is better? Are you enough with FNAC or you definitely want a biopsy?
What changes between FNAC and biopsy that will change your decision about neoadjuvant?
That's what I want to ask pathologists.
Biopsy means I am taking it as a FNB.
Correct.
So you are taking either FNSC or FNB from the same procedure, and it will give us more tissue, more cells to, we will be able to confirm better if it is malignancy. Suppose you get a positive FNSC. Then will also it will serve the purpose. That will serve the, then now if you want to do some IHC or something into that. See, from the FNAC also we can make the cell block. That is not an issue.
But,
the FNAC also we can do sequencing. So that is not an issue. But FNAC, the sample should be adequate. So either FNA or FNB or FNAC both will serve the purpose, but for the more tissue, FNB will be preferable if you are taking.
So this question had come from one of the slides which was shown that we have to take a transhepatic biopsy and blah blah blah. Something was shown. So at that time it struck to me that I think FNAC is better rather than biopsy. Then it came to me, is it the biopsy that is required for IHC? And so the message is that FNA will give you equal IHC. You can do IHC with FNA slides also. I think I am correct if you are getting it positive. You can make a cell block out of that.
But in the neoadjuvant setting, are we looking at anything other than the presence of malignancy, like as of today?
Is it adeno? Is it squamous? Is it something else?
It is a
Like
type of malignancy.
Yeah.
As that on an FNAC they will be able to
they
say.
will be able to comment.
Yeah, that's what I'm saying.
Talking about the type of malignancy, 95% it is always adeno.
Adeno.
Even if we see few squamoid differentiation, we see that in poorly differentiated gallbladder adenocarcinoma. So we never diagnose on the FNA or limited sample material. It is a primary squamous cell carcinoma. So it should be taken as adeno with some squamous differentiation.
So from pathologists coming back to the surgeons again. So how many of you do a Taj Mahal resection for a carcinoma gallbladder?
Taj Mahal resection is not needed in this. It is only, you mean to say extended liver resection and bile duct?
I have not done.
Anybody doing? Dr. Sadiq wants to say something, I think.
Central resection.
So it's segment 4B5. Normally we have been doing for 3 to 4 centimeters, which has come down to 2 centimeters. Taj Mahal, which was at one point in time was very much propagated, is no more done. Now coming back to the incidental carcinoma gallbladder, you get a biopsy of which has been taken by patient. Normally we expect it to be after 7 days. The patient comes after 1.5 months and he says that he has biopsy which is CAG. How will you take it?
After 1.5 months he comes. We will review and we will investigate the patient for further. We will ask whether all the things is to be done.
So if he comes after 1 week, you will not do, but if he comes after 1.5
No, no.
months, you will do.
No, we will do.
The same patient is coming, one patient is coming after 7 days with a biopsy, one patient is coming. Will the time factor change your plan of management? And maybe the extension of the question is, for how long can you go ahead with the surgery? After how long period? Maybe after
No, it is not that. The studies have shown that 4 to 8 weeks is a good time to do the surgery. But still, after 8 weeks, slight there is decrease in survival. But if patient comes after 8 weeks, we need to do all the things which we are going to do at 4 weeks. And we have to give the benefit of surgery to that patient also. Though survival rates may be slightly less, but we need to do that.
So basically what you're saying is that the need to stage the patient at whatever time the patient comes to us
the patient has come,
remains, and then do the management accordingly.
Accordingly.
That will stay for earlier
Of course.
also.
So if the biology is playing a role when you stage, it would be.
Yes.
So I'll come to that also now in a minute. So now you have a patient. So the message is, the patient, whenever he comes, he needs a complete evaluation, and if the patient can be benefited by surgery, he should get in for surgery. But if you get delayed patient without any metastasis, without any nodal disease, and PET negative, this patient is going to behave better. So he is in your course of treatment. Rather, he will be in a better surgical move. Second thing, suppose this same patient has a papillary carcinoma, incidental papillary carcinoma, and versus, so will that change your plan of management or evaluation?
The evaluation will be the same. The evaluation and the management will be the same. Evaluation will be the same.
Maybe anybody, sir? Kapoor sir, yeah, I know.
So papillary carcinomas are known to be more frequently multifocal, multicentric. They also tend to break the point which I think Sumara you made, that, or Dr. Pooja made, that in the specimen bottle you should look for fragments, because a polypoidal lesion can fragment. So they are more likely to have multicentric, multifocal, intraductal CBD deposit, and that is why some groups, especially in Japan, because their papillary carcinoma, which usually occurs without gallstones, is more common, they routinely advocate a CBD excision, although they don't do it in every case. But in papillary carcinoma, they say that CBD excision should be done. But my objection to that is that if it is going to be multicentric or multifocal, what about the intrahepatic bile ducts? You are not taking care of them. So that's a debatable thing. But the other is that in papillary carcinoma, probably your threshold to give adjuvant therapy would be lower. So even if there is no other indication like T or N stage, but if it is a papillary tumor, probably you should give adjuvant chemotherapy.
Regarding this question regarding the delayed presentation, there's a group in UK which actually does a delayed staging of these patients. I think they stage their patients at around 3 months.
3 months
post their presentation, and they have shown that they've avoided unnecessary surgeries, is what their conclusion. I don't remember the numbers.
But that group has shown that the patient who the survival in the patients means that the some patients presented with the upstage.
No, basically what you're doing is you're giving a biological selection.
You are seeing the
selecting
tumor
patients with
biology, whether
good,
that means.
favorable biologies.
But still, some patients have in that group. Some patients have come in upstage disease.
scenario, if there's a young patient who presents with gallbladder cancer involving the entire right lobe and segment 4 with no distant mets on PET, so and segment 2 and 3 is free, no vascular invasion, is adds a possibility for patients with gallbladder cancer, or should we avoid it?
Pardon? The patient is a known case of gallbladder cancer.
Gallbladder cancer with involvement of the entire right lobes and segment 4. Segment 2 and 3 is free. There is no vascular invasion, no distant metastasis on a PET scan. Young patient.
So you mean to say whether to go for surgery or not go
Yes,
for?
yes.
So
But volume would be low if it is only
right.
segment 2 and 3.
The extensive resections in gallbladder, getting an arterial resection surely improves the survival, but the volume of disease and extensive liver resection is not going to help much of that case in that.
But, sorry, yes.
So obviously this is quite an advanced disease. We don't know the biology. I would rather do a CA19-9, see how levels are. I may do a PET CT in this patient to see for metastatic disease. And if all that is negative, I would still give neoadjuvant therapy for this to see the response to treatment. So I won't think of going for an ALPS in this patient because the likelihood of cure in this is very low. So I would rather look at the biology unfolding in front of me than going in for surgery straight away.
Yeah, I agree. In fact, some of these tumors, actually, a much smaller tumor but with extensive nodal metastasis may have a more aggressive biology, and neoadjuvant would allow you to see whether this patient actually falls in a good biology where you can offer surgery later.
So our medical oncologist had a concern that suppose if we give neoadjuvant, then and if she doesn't develop a metastasis even after the neoadjuvant, and then we consider ALPS, so the remaining liver will grow or the chemo effect will be there on the liver.
Yeah, I think that is a very valid concern, and I don't think we have enough data to answer that question.
Sort of this Anita Balakrishnan paper, did I get you correct that they are saying even T2 no reoperation? No. I'll have to read it again. But T2, there is no debate, there is no controversy, reoperation has to be done. No, T1B is okay. So, and T2, the only debate now is the peritoneal and hepatic side. T2A and T2B, and there are some Korean studies also which show that if it is T2A, you need not do the liver wedge, you only do lymphadenectomy, although personally I don't agree with it. But T2 for reoperation, there is no debate. I will read that again, and if she has written that, we must write to her that this is. You didn't highlight that. Yes. Okay. So we'll have to read it again. Now the point which Ajay was asking, I would extend it further. Incidental gallbladder cancer, for whatever reason, patient did not receive reoperation and did not undergo chemotherapy. It was T1B or T2, even T2, and the patient comes after 1 year. You do a PET scan, there is no disease. What would you do?
We will wait for that. Because the tumor after 1 year also the patient has not developed. I think if it is a T1B disease, nothing is to be done. Even at T2 stage after 1 year, no disease, PET scan shows nothing. I don't think so there is need of re-exploration in this patient.
Yeah, because as an extension to that, Dr. Mahesh Goyal's group, Tata Memorial, they have shown that in T1B, if the PET is negative, I think somebody said that they don't do wedge, but I think they say no reoperation.
No reoperation.
So T1B, if the PET is negative, they are saying observe the patient.
For staging purpose, lymph node has to be, for staging purpose, lymph node dissection, still it is there that we can go for avoid liver resection, but for staging purpose, lymph node dissection has to be needed.
I personally don't agree with that. We will have to wait and see what happened to these patients over a period of time, but that is what they have written. No, once the diagnosis of incidental CAGP is made, I think most of us for doing a PET scan would wait for the surgical changes to settle. So I suppose you would like to give at least a couple of weeks time for you. Otherwise, the surgical changes may look like residual disease. But in that paper, they have said that in T1B disease, if PET is negative, no reoperation, just follow up.
Sir, in Tata Memorial, I don't think any patient with T1B would be coming at day 7. All the referral centers would get patients in the delayed this thing, so that probably would not be.
So, you know, we are talking of we have to do and there is cure, but there is a good body of literature which is collecting. It says irrespective of T stage, if there is residual disease, it portends poor prognosis.
Yes.
So you're not going for cure. You're going to surgery to find out whether this patient is good biology or bad biology.
Why not do that with neoadjuvant?
Or with other methods of, so that's what this study by Tata Memorial with PET scan said L PET positive, that is a local PET, no positive, and there is a difference in early stages that no positive in PT2 may have some residual disease in the lymph node, but never in the liver. So that's why if there is no disease, they would not suggest doing it in that scenario. So I don't know whether the reoperation is for cure or for stage.
So I keep on saying so this always, because right from the time the first this thing on re-exploration came from Memorial Sloan Kettering, Duffy et al. I always they did for their 10 years results. They are the most aggressive surgeons in the US for gallbladder cancer, and what they find is best results are when there is no disease, means you are taking out normal tissue. So that's what we are saying. So you.
That is going to get benefit if there is no residual disease present, if your nodes are negative, if you have a node positive disease, even if it is T2, if there is node positive disease, this patient is going to fare bad.
So if you have a benign CAGB, that's what you are saying.
Yeah, even if you are doing extensive resection, you do whatever lymph node clearance, you do whatever liver resection, they are going to fare badly. Only thing that is going to help CAGB patient is he is having an early disease. That's all. Otherwise, they don't.
Ma'am, that is why, that's what I'm saying. For referral centers, usually no patient comes within the first week. But if we are own, yeah, that is for that.
Ma'am, regarding the reoperation of these patients, like the patient who has incidental CGB, in the literature, approximately 4 or 5 studies where I have seen, because I have collected the data with the Kapoor sir regarding this, and only one study, which was a prospective study, which was saying that delaying the treatment in these patients, which is beneficial because they have basically knows that the biology of the disease. The person who is having aggressive disease will get disease within 3 months. So that's why they have told that we should delay the surgery in these patients. So they can select the group of patients, and we can go, if the patient is selected, they are having metastatic disease, they can be ruled out, and other patients they can subject it for the surgery. And one or other 2 or 3 studies, then there are retrospective studies. One of the SGPGI studies, they have suggested 4-week duration. Within 4 weeks they should go. One study from another group, they suggest 12 weeks, and one in between, around 6 to 8 weeks. So we have three groups: early, within 4 weeks, 6 to 8 weeks, and 12 weeks. But the only prospective studies they are suggesting we should delay the surgery in cases of incidental CG.
Anand, dekho, there is one thing which we have to understand. For all malignancies, the neoadjuvant principle remains the same. What you are saying, the principle is, if the behavior of the disease is benign, if it is not very aggressive, you are going to save. So the surgeons tend to get the lesser number of surgeries into their basket, and only those which have a good survival. So that is the basic principle of delaying anything. That is same principle for neoadjuvant, same principle for CAGB. If you delay somebody who is going to have metastasis, that's why you are getting a PET scan immediately after that. If he has mets, so you don't operate that. So delaying is as good as that. But if the same patient had only a primary disease at the same site, and if you resect it, he may have survival. He may get a.
Sir, I don't agree with Ajay sir. Sir, means you are saying that whether a T1 lesion we operate, it is having, there is no further disease, the patient will have good survival. Even we are increasing the survival, overall survival to the patient who are having T2 or like that by clearance, by doing staging or clearing the disease. So saying that they can be put in the same basket, whether the patient has got a survival of 2 years or 5 years, it is not.
I'm not saying that. I'm not saying that. What I am saying is you get a small proportion of the patients in your surgical basket who will have a good long-term survival. What we are telling is a group of patients who will have a survival of 10 months vis-a-vis 12 months or 13 months. So that 3 months additional advantage you are telling. I am telling the group of patients who will have a better long-term survival. Those, if you do operate later and if they don't have metastasis, definitely they are the ones who are going to survive better as compared to any other.
One thing was more, sir, in case of incidental CGB, we are getting patient outside. So usually we don't know the exact history like bile spillage, which we were discussing previously. I think maybe these patients who had a bile spillage, they can be get selected with waiting for some period, because the patient who had a bile leak, probably they will develop peritoneal mets within few periods of time.
Dr. Anand, because it is very difficult to get this history, and even the lab quali has been done at a periphery level, at a big, I don't think so, they are using a endobags also. So in incidental carcinoma, if we get that history, giving a patient treatment benefit, I think that is a more appropriate than asking the patient to wait for that on this.
This recent evidence which is coming that delay the treatment of incidental gallbladder cancer to 4 weeks, 8 weeks, I think there is a report 12 weeks also. How can you wait for 12 weeks in a patient with known malignancy, possibly early curable malignancy, and give no treatment? Will it be justified? Are there medico-legal implications? While you are waiting, should you give neoadjuvant treatment? Those are the issues which need to be, I think, debated. Because in any other malignancy, would we tell the patient that no, we would like to wait for 12 weeks to see the biology of the tumor without doing anything?
So these are all retrospective studies actually. Patient
making this recommendation in the end.
That is the poor part about it. So the thing is that you can't equate two apples and oranges kind of a thing. If someone was a CA prostate supposedly, you could say a watchful waiting is a very good option, and I have personal experience. My father-in-law has, and 3 years down the line, same stage. But a patient malignancy which we always know has such a poor prognosis, despite all the aggressive treatment that we can use, adjuvant, neoadjuvant, surgery, everything, and then to delay them for 12 years just for the sake of selecting the better outcomes is actually a poor way of treating patients, and not ethically advisable.
But maybe doing them early and not getting the same result.
No, not the surgery part. I am saying giving them treatment. If not a surgery, which is an invasive thing, then probably a chemotherapy if the patient is able to tolerate that. If a couple of cycles of chemotherapy and patient is tolerating and he is actually responding to that, then maybe you can, so kind of a perioperative therapy. You give a perioperative, give 2 cycles, 3 cycles chemo, see if the patient is behaving well, not actually progressing, and then do the surgery. Maybe that kind of a progress can be done. But to wait for 3 months in a patient who already we have diagnosed there is his malignancy, probably we won't be able to justify. That's what my.
So 5 more minutes if there are any other questions or comments.
For these patients, I think this is the ideal time to do a different kind of thing for these patients rather than just wait for 12 weeks. So I am a medical oncologist, so I'll say why not give them, chemotherapy and see. Recently, Tata has published this data regarding they use a lot of neoadjuvant chemotherapy in biliary tract cancer. And they have, I think, published, they have compared 250 patients, they have received neoadjuvant compared versus who have received adjuvant. And their overall survival was same. They were not selected based on this criteria that there was incidental, but they have taken locally advanced or advanced gallbladder. So whether they have used adjuvant or neoadjuvant, the survival was same. But we might be the same thing. We might be able to give some treatment. We know that all patients will not get benefit from that chemotherapy. Around a 20-25% of subgroup, response to chemotherapy might have that benefit. So we might be able to give benefit to a subgroup of patients, but not to all.
According to the MSKC, there is a study of neoadjuvant therapy. They say it is better for the micrometastasis or aggressive tumors. But slow growing tumor, the neoadjuvant therapy has not been very helpful in their study. So if there is an aggressive tumor and it is not advanced, whether it's a locally advanced, then we can try this new adjuvant therapy according to their study.
One small query regarding the new adjuvant. I'm diverging from the incidental part. So, to give new adjuvant, how do we define whom to give new adjuvant? What is the inclusion? What are the patients you're going to include? Because locally advanced can be a lot of things. Locally advanced can be a local organ involvement. Locally advanced can be a vessel involvement. So, we have to clearly define these criteria. I did a very small study, about 7 patients. I had a trial when I was for 2 years in Himachal. 7 to 8 patients only. 4 of them responded really well, but most of them had local organ involvements. Only one was in which vessel involvement was there. And this was actually an offshoot when I had read about the first paper of Tata, which was about 38 patients initially. There also it is diverse. So we have to first define who will actually benefit with the new adjuvant also, whether it is the vascular, the local involvement. We haven't defined that.
I
Maybe
think
that is one
Tata-
area we have to think about.
Tata, they say like T3, T4, N1. They've taken as loco-regional disease or locally advanced disease.
But the
at
most
least in
of the patients who are actually under sickle ma'am are actually those who are vessel involvements. Because once right hepatic artery is involved, larger chunk of liver is involved, you're not operating. So only thing you're left with either portal vein embolization or give new adjuvant. And we have seen neither portal vein with us, even in AIMS New Delhi, hardly any patient of portal vein embolization eventually leads to the operating table.
I think neck tumors in any case are very different from those in the fundus and
that
the,
is what I'm saying. So you have to define a clear subset of patients which actually are going to benefit with the new adjuvant approach also. So not just taking all diverse patients and then seeing, because 178, the second was 178, now 13,000 something.
1,300 patients.
1,300 patients has been published. So, but that is a diverse group.
Yeah, because that's retrospective and therefore again the need for...
So we haven't defined
prospective
what we are
studies.
looking for. We haven't defined what is our target population or the target. And we have to first define that and then go ahead with whatever.
So Tata is, I think, doing a study, Polka GB study, in which they are giving neoadjuvant, they're comparing actually neoadjuvant chemo versus neoadjuvant chemo RT in patients who are potentially resectable. I don't know the exact criteria.
So
they have 6-7 criteria
again,
in that.
One of our residents already did this study long back, and we actually abandoned this study because chemo RT versus chemo, we did not find any advantage. And because it's very difficult to give RT at a place where GB is, a lot of complications, patients do not tolerate, and we did not have any successful.
In the neoadjuvant setting, maybe more benefit, but
maybe.
Adjuvant, it's actually very, very difficult, but maybe in neoadjuvant. That's why they are doing in neoadjuvant.
We did in neoadjuvant only, small subset, pilot study, 20 patients each. Poor results. For us, at least, it was poor results. Maybe they have better results. We are not sure.
They have defined some subsets. I don't know exactly, but for patients who had some features resectable, they have not taken. They have taken sort of potentially resectable patients only in that study.
I think we have had a very avid discussion, and so now I think it's time to shut up the guys. Thank you.
Thank you, the panelists. Thank you very much. I must say that when Anu was introduced, it was that she was a professor of surgical gastroenterology at SGBGI Lucknow, but that probably was incomplete. She is one of the few people in India who have made major contributions to gallbladder cancer. She knows a lot about gallbladder cancer, and in all the publications which have emerged from SGPGI AMS, she has played a very, very important role. So with that, I think we come to the end of today's session. Just two announcements. Today, for all the faculty and the accompanying persons, there is a dinner again at the same place, Pride Amber. And tomorrow, the chairperson, emeritus and chairperson of the university, I have sent the invitation to all of you, has invited all the faculty of our conference, as well as there is another conference which is going to be held tomorrow and day after, a Medical Science Academy conference. So the joint banquet dinner, where the senior administration of the university will be present to welcome you. So please keep your evening free for tomorrow also, all the faculty and the accompanying persons. Thank you very much.